Welcome to the St. Luke's Health Talk series, where we bring virtual live opportunities to you, our community members. To find additional classes and offerings, please go to www.stlukesonline.org/health talks. Today, we welcome Dr. Mathew Larsen, who is the St. Luke's Emergency Medical Director, and James Rhom, Community Health Emergency Services Supervisor. They are both located in the St. Luke's Magic Valley region. I'm Sarah Hagerly with St. Luke's Community Health as a program coordinator. Here are some housekeeping tips for you in our virtual live event today. You will have an opportunity to ask questions throughout the presentation with the chat feature. There is a Q&A icon on your screen, typically at the top right side. Click on Ask a Question at the bottom, type your question, and click the airplane icon to send. Please feel free to type your questions throughout the presentation, and we will save questions for the end. I will advise you of our disclaimer. The information in this video should not be construed as medical advice. The video is property of St. Luke's and will be made available to you for a limited time for educational purposes. Our health talk today is Save a Life, and we will be learning techniques to know after you've had a reason to call 911 for emergency response. James and Dr. Larsen, thank you for presenting today.
Thank you. So today we're going to kind of teach you 4 basic things. First off, we're going to talk to you about how to activate the emergency response, call 911, and some of the things you need to do there. And then we're going to walk you through some trauma education with Stop the Bleed and a high-level view, and then what to do in a cardiac arrest when we talk about hands-only CPR and how to use automated external defibrillators, AEDs, that are around the health system and around the community in a lot of different venues. So first off, we want to talk to you about call to help. So Dr. Larsen, what are some of the key points that you want to portray when we start talking about people calling 911 and what they need to have beforehand?
So I think obviously having a ability to call 911, we all have cell phones. Cell phones that are even not active on a system could still be used to call 911. I think the number one thing that we teach EMS providers and police and fire is to ensure your safety. Don't make yourself a victim. Make sure you're safe. Because now we don't want 2 people to rescue, versus 1. The key to any traumatic situation or acute situation is not to panic. Panicking only makes us not be able to respond. Another thing that we see is folks who don't know where they're at. You're driving, you're on I-84, you're driving in your community, and you don't know, you know how to get there, but you don't know exactly where you're at, and those locations can be really valuable. 911 can ping a location, but sometimes it's a broad area. It can be a significant radius that we're having to search in to find those. So kind of have an idea of where you're at all times, so you can give some detailed information. And then stay online with those dispatchers, provide them the information they need. And like I say, they want you to stay online because it's intelligence that they're gathering to provide to the first responders as to the situation and what's going on. And then we're going to, as James said, we're going to teach you a few things. We're not going to make anybody a paramedic or a doctor or anything today, but we're going to teach you a few things that you can do to really create time and space, which is what we're trying to do. We're trying to create time to allow the professionals to get there and do what they need to do to increase the chance that the individual who's having a medical emergency will be able to survive and have a good outcome.
Yeah, and these are the things that when you call 911, they will help you with. A lot of times dispatch centers across our region have protocols in place to where they'll walk you through some of the things we're going to talk about right now. So the first one we want to talk about is Stop the Bleed. This is a national program through the American College of Surgeons and the National Association of EMTs. But we want to talk about the ABCs of Stop the Bleed. So First, we have that's the alert. That's what we already talked about. All those things that were discussed, and calling 911, make sure you know your location, know what's going on, are able to talk to the dispatchers and convey that over. When we talk about the B of the ABCs, we talk about bleeding, identification, and recognizing the bleeding, and we're going to talk about that a little bit more. And then the third one, or the C in the ABCs of bleeding, stop the bleed, is actually compress. And we're going to talk about compression, we're going to talk about packing of wounds, and we're going to talk about tourniquet use when we get down there.
And I think it's important to call out that that's different than the ABCs of CPR. So those people who are CPR certified, it's different, but it helps you remember the things you need to do. And I think the alert one is, again, super important, because as an ER doctor, I don't treat penetrating trauma. I stabilize it long enough for our surgeons to do what they need to do to stop the bleeding. So getting the patient to where they can get that definitive care is the most important thing, and that starts with the 911 call.
Yep. So when we talk about bleeding, so we talk about finding the bleeding. So we want to talk about how to expose and locate that bleeding. And then the next thing we want to do is we want to identify life-threatening bleeding. So Dr. Larsen, can you tell us more about the 3 different regions that we're gonna assess, and kind of the differences between those 3 regions?
Yeah, when you look at bleeding in individuals, you look at data research about where we have good outcomes. We have the best opportunity when those hemorrhages are in that first area on somebody's arms or legs. First of all, it may not be life-threatening bleeding. Second of all, if it is, we have really easy, simple ways with tourniquet use to stop that bleeding. Some of the more complicated areas are in on the second figure. You can see areas highlighted in the groin and up in the armpits, which are called junctional areas. Those are sometimes difficult. You can't put a tourniquet on a junctional area. So you're talking about areas where you really need to focus on compression. And that was the C of the ABCs. Starting or really focusing on compression. Once you started that compression, keeping that compression going to slow the bleeding down and to help coagulations, help the blood clots form. In the third area, the mid-torso area, the reality is that damage done to those areas is hard to compress. You don't get much benefit from compressing because those areas are full of potential space. There's lots of ability for that blood to go into those areas. There's lots of tissue and organs in those areas that can bleed, and you're not really going to necessarily have a whole lot of impact by pushing compression on those areas. They're areas that are dangerous and have a higher mortality rate as you kind of go from left to right, from the extremities to the junctional areas to the torso. You have a lot higher mortality rate in those areas. So that's another thing to keep in mind, is that bleeding on the arm, if it's a penetrating injury to the arm or a large laceration from a car accident, it's really fairly easily treatable, and we can really significantly increase the chance of good outcomes, even in a significant bleeding.
Mm-hmm. So, and then the number 2 thing, the thing we want you to look for is we want you to look for life-threatening bleeding. So when we talk about life-threatening bleeding, we're talking about looking for things like spurting blood, or it just won't stop. Spurting blood is indicative of arterial bleeds, right? So we want you to be able to find those. We tell you to expose because we're looking for those large pools and soaked clothing. So trying to find where the injury actually is on the body, remove the clothes or cut the clothes to expose those things. And then life-threatening bleeding is also loss of limb, can cause significant life-threatening bleeding. And then watching their vital signs or where they're interacting with you, if they're unconscious or confused or starting to have an altered level of consciousness or just a general confusion, that can be a sign of significant blood loss, right? And those are the things that maybe you have exposed and you don't see a lot of blood loss, but there may be some internal bleeding that's leading to that altered level of consciousness or the confusion. So that's why we ask you to look for those life-threatening bleeding, right? We have to be able to identify and locate it before we can treat it.
And I think that's an important point, James, that there can be a lot of bleeding that isn't on the outside. So you're maybe not going to see the giant pool of blood if somebody's been say shot in the stomach or had a knife wound in the stomach or some degree of injury. It may be less remarkable than you would think, but the way they're acting, the way their mental status is changing, they're lightheaded, they're dizzy, they're nauseous, those can be indicating there's a lot of blood loss inside of the belly or inside of the extremity, the leg or the arm, and we need to act appropriately on that.
So once we identify that bleeding, the first thing we want to do with all bleeding is we want to find something, a clean cloth or a prepackaged dressing or something like that, to be able to first apply direct pressure to the wound. So we're just going to find that clean cloth. This wound here we have on the screen, we're going to apply direct pressure. And a lot of times it's more pressure than what you would think. So you may have to get an arm into it, kind of lean some of your body weight into the wound to be able to stop the bleeding. And then when we get to junctional wounds, remember those wounds that are in the armpits and the groin and kind of in the neck, we may actually have to take that cloth and actually put it down inside the wound. So actually pack the wound, put the cloth, the gauze, whatever it is, down deep into that wound, and then apply pressure on top of it. So we're actually trying to get those small vessels, those arteries, venules, arterioles down inside the extremity or inside the body. And we're actually trying to push down on those so that we can actually stop the bleeding and start that clotting cascade to actually stop the bleeding completely. And then when we see, we talked about the junctional wounds, we talked about packing those junctional wounds, but we've got extremity trauma like this leg here or amputation or otherwise, then we definitely want to use a tourniquet. We're going to get into tourniquets a little bit more, but you can never go wrong with using a tourniquet. We recommend them for, even if you're questioning it, put the tourniquet on, right? Don't hesitate to put a tourniquet on.
Yeah, so, we teach a lot of law enforcement this who aren't medical providers this, and we always say, when in doubt, put a tourniquet on. If you're looking at bleeding and you think, wow, that's a lot of blood, it may not be as much as you think, but you can't go back in time. If the blood's out, it's out. So we want to stop that bleeding, and we know that through research and data that extremity hemorrhage, so hemorrhaging on the arms and legs, is the #1 preventable cause of death in traumas, in penetrating trauma.
So when we talk about tourniquet application, first off, we always teach apply the tourniquet high and tight. Dr. Larsen, there's some differing ways to teach this. Some people say 2 to 3 inches above. Some people say high and tight. Why do we recommend high and tight?
So there are 2 different ways, and both of them quite honestly do work. So if you've been taught in some kind of other class, go 2 or 3 inches above the injury site. It's not wrong, but a couple of the constraints around this are if you're in the lower leg or the lower arm, there's 2 bones there, and the blood vessels actually go between the bones. You can still compress those blood vessels. You have to have a little more pressure, and it's a little more nuanced in how you watch that and make sure that the bleeding stopped. With James and his colleagues, paramedics, if they decided to do a low tourniquet, they've been trained to do that, and I think that's reasonable. The other part of high and tight is we never want you to take a tourniquet off. So once a tourniquet's been applied, if the bleeding hasn't stopped, we really want you to apply another tourniquet. If you're doing it right above the wound and you don't have space between that tourniquet and the joint, because we never want to put a tourniquet over a joint, we won't get good blood control and we can damage the joint, then you've got to go above that again. And by that time, you're almost in the high and tight region. A third reason why, and again, going back to when we teach law enforcement this, we want you to be able to apply a tourniquet to yourself, which is really much easier to do if you're doing it up towards the core of your body, up on your armpit, up high in your arm, in your groin, going as high as possible. It's much easier to get the leverage to create those tight and to apply the tourniquet if it's high and tight.
Right. So like Dr. Larsen talked, when you put those tourniquets on, we don't put them over joints, right? We want to don't place them on elbows, knees. we want to tighten that tourniquet. Once we get it on, most of them that are pre-made to tourniquets have a big Velcro strap. We want to tighten it down as much as possible, as tight as we can with force, Velcro it down, and then we're going to use that windlass clip to twist it until the bleeding stops. And then we talked about this. We don't ever remove tourniquets. Don't remove tourniquets. We're going to leave those on until this trauma surgeon is able to see the person and able to take that off and actually have definitive treatment for the bleeding vessels. We talked about you can apply it to yourself. You can apply it to others. That's why we teach the high and tight is for when you're doing it to self. You can put it over clothes. Minimal amounts of clothes when we're talking, we're out there in the backcountry, we got some base layers on, maybe a shirt, a light pair of pants. Definitely don't want to put it over any large jackets, big puffy coats or some of those. We may not be able to compress the vessel as well, putting over bulky clothing. But you can put it over some minor clothing. And tourniquets hurt.
They do.
Yeah.
And what we teach is if it doesn't hurt, it's not working.
Right.
That's one of the ways a tourniquet's working is because it hurts. It actually can apply or can be more painful than the injury. A gunshot wound to the arm may not hurt a ton if it's just soft tissue, but that tourniquet should hurt. And then it should be followed up by numbness. I think we've all had the experience of falling asleep with our hand above our head or something like that, and we get that dead arm. That's really what you're inducing when you put a tourniquet on. You're stopping the blood flow. So as the tourniquet's been on for a while, you should actually start seeing the patient or the individual have that same sensation where it goes numb. And many of us were taught some of us are older than others, James. But many of us were taught way back in the day, Boy Scouts or Girl Scouts or wilderness survival or whatever, about the idea of loosening the tourniquet to let blood flow. I find that such an odd concept because the reason we put the tourniquet on is because the blood flow is disrupted. It's open, it's perforated. So all you're really doing is kind of leeching the patient, like bleeding them out a little bit and then stopping the bleeding again. So that's why we don't take it off. And that's why we want to make sure that it's tight because you're trying to keep blood from getting to that injured vessel. That's the key is to keep blood from getting to that injured vessel.
And when I teach stop the bleed courses, official stop the bleed courses, I always tell everybody, if a patient is complaining or a person is complaining about the tourniquet hurting, that's great because it's working right. Yep. And because they're still talking to you.
Yep.
So definitely all things we need to think about. And then we talked about a second tourniquet may be required to stop the bleed. That's why we teach the high and tight, so we can just put it right below that first tourniquet, tighten it up. If you have a tourniquet that's a little bit lower and you need to put it over the top, put it over the top. Just same technique and everything applies as the first tourniquet, but definitely apply the second tourniquet if you need to. And then let's talk a little bit about commercial tourniquets. So there's a lot of talk about when I was in Boy Scouts or when I took a woofer class or one of those courses about using improvised tourniquets. Improvised tourniquets are great and they can be effective. What we want you to really think about when we're talking about the different types of tourniquets is that you are educated and proficient in using whatever tourniquet you have available, right? So when I teach the class, I ask in the classes, I always ask who learned how to build a tourniquet with a belt or a handkerchief with a piece of rope, any of those things. I always ask, and then I say, okay, here's a handkerchief. Hurry up and make me a tourniquet, right? And 9 times out of 10, people don't remember how to put on a tourniquet with a handkerchief. So our recommendation is commercial tourniquets and learn how to use the tourniquet.
Yeah, and I think that, another positive of commercial tourniquets, and again, if you're in a situation where it's saving someone's life by applying whatever you need to apply, that's what you need to do. But one of the advantages of commercial tourniquets is they're wide, so the pressure gets distributed over those blood vessels and that tissue more widely and causes less damage to those vessels. So we know that we can put tourniquets on people. We've got a lot of data from our Middle East conflicts with the use of tourniquets in the military. We can have tourniquets on for several hours and not have permanent vascular injury or neurological injury. We do know that improvised tourniquets, ropes, cables, stuff like that you may have to use because that's all you have to save a life, can be more risky for causing that and shouldn't be on near as long. Doesn't mean again that you don't use it. We've had situations where some of our staff or one of our St. Luke's nurses had to use a rope and a stick, saved a guy's life. It was on for a few minutes before EMS arrived and were able to put a commercial tourniquet on, which was going to be a bit safer for the overall situation. But if you have a commercial, if you carry a bag, a first aid bag, something like that in your car, you really should consider having a good, high quality, because there's a lot of stuff on the market and some of it isn't great, but a high quality commercial tourniquet that is designed for that use.
Okay, so we've covered a lot of the trauma topics, and now we're going to move on to CPR and AED use. So many of us out there, I think CPR has been around for
60 years,
60,
a little under 60 years,
right? A lot longer than I've been
60s.
around.
Yeah.
You may remember those days. And I think a lot of people know the basics, but we kind of want to talk more about it. And one of the biggest keys in the chain of survival in cardiac arrest is AED use in early defibrillation. So we'll cover that as well. So the first thing we want you to do when you have somebody that you come across, you want to determine their level of responsiveness and check for breathing, right? We always teach that. Look, listen, feel. We want to ask them, hey, are you okay? Maybe tap on them. We talk about the head tilt, the chin lift, if it's a non-traumatic patient, or we talk about a jaw thrust in a traumatic patient, but opening that airway is what we're talking about. And then we want to look, listen, and feel for breathing. So we're looking for the chest rise to visibly come up and go down. We're listening for air to be coming in and out of the mouth, and we're feeling with the back of our hand or maybe the side of your cheek, that air moving in and out of the patient's or the person's mouth. And listening for those things, and if it's not happening, being able to do an airway maneuver to open up, to allow the air to move back and forth.
I don't think we can overemphasize number one. We see this all the time. Somebody passes out, falls down on the ground. People want to help, so they come up and they start doing chest compressions. Mm-hmm. And the person says, stop doing that because it hurts, because they're now awake. So be aggressive and, yell at the person, maybe give them a little stimulation, like shake their arm or even their chin a little bit, to see if they're truly unconscious. If they are talking to you, they may have a medical emergency still that requires them to be in the ER as fast as possible. But they have a pulse if they're talking to you. Mm-hmm. That's guaranteed, that they have a pulse. So really, number one, really, be aggressive about getting their attention.
Okay, so after we've looked, listened, feel, we teach you to call 911, right? Or you should have called 911 already. We've covered a lot of that, making sure that you're accessing the emergency service system, emergency medical system. And then we want you to go straight to chest compressions. If the patient does not have a pulse, is not breathing, we want you to go straight to chest compressions. So to start chest compressions, you want to place both hands on the center of the chest, just like we have demonstrated here in this picture, right? So we're going to find that center of the chest. We're going to interlink our fingers and put it right over the top. And then we're going to push hard and fast, at least 2 inches for adults. And then we're going to perform 30 chest compressions, and then we're going to check for the breathing again, and then go back to chest compressions. So in the lay responder courses, or when we're teaching lay responders, non-medically trained people, we just want you to do chest compressions. We want you to do 30 compressions, check for breathing, go back to 30 compressions, and continue that for a rate of about 100 per minute. And there's lots of different songs out there, right? The Bee Gees, Staying Alive. There's some more modern ones, but I'm not real hip. No. Just ask my wife and kids.
Everybody knows the Bee Gees, Staying Alive.
Right. So remember that 100 beats per minute. I think that's the number one thing that I've seen as a responder. We show up, either chest compressions are way too slow or they're way too fast, right? And after a while, we kind of get the hang of it. I can kind of tell you that you're in 100 beats per minute. But make sure that we're getting a good rate. We want, when we're doing chest compressions, what we're doing is we're actually not so much pushing on the heart, but we're compressing the chest cavity and then allowing full recoil of the chest so that we're able to refill the vessels in the heart and be able to push some of that blood back out to the body, right? So we want full compression, full relaxation of the chest so that we're having good refill. And it's a lot more on the pressure changes inside the chest than it is necessarily pushing on the actual heart muscle.
Yeah, and I think a couple pro tips there, like James said, all the way in, all the way out. You are going to feel some weird stuff if you've never done chest compressions before. Ribs will dislocate, ribs will fracture. Those things are all things that can heal. If somebody has a pulse and they survive, those things will heal. Try not to bounce and come off, because you've done your due diligence finding the right spot and you've locked your fingers in and you're in a nice position. If you bounce off the chest, you really have to go find that again. So you want to come up all the way, but not all the way off to where you're bouncing on the chest. We're not hitting the person. We're smashing that chest wall down and then letting it come back up again. So keeping those in place and locking your elbows. If you try to do it with your elbows bent, you're going to exhaust out really fast. Whereas if you do it with your elbows locked, you're now using your hips and your core muscles to push instead of your arms. Because we're not pushing with our arms, we're actually pushing with our bodies as a lever.
So you found somebody, they're pulseless, you started chest compressions, you've called 911, you're doing everything great. The next biggest link, and probably one of the most important links in the chain of survivability, is we want early defibrillation. We want to be able to catch those VFib, VTAC arrests and be able to shock that heart back into a normal rhythm as quickly as possible, right? We want that pump going again. And so this is when we talk about automated external defibrillators. These are everywhere. These are the Zoll product. There's a lot of other products from lots of other companies out there, all over all of our communities out there. And what we want you to do is we want you to know where those AEDs are and start to familiarize yourself with some of those AED products that are out there. So once you get an AED, someone gets the AED for you, brings it back to where you're working with the arrested patient. We want you to be able to locate the closest AED like we talked. And when I'm walking around, like in the health system, I'm walking around in the community, I'm always looking for those AEDs, right? Just making sure I know where one is or know if one's available, right? Law enforcement officers across our state and region carry them. They're on every ambulance, on every fire truck. They're everywhere, right? They're in the malls. They're all over the place. Just making sure we kind of know where those are. Once we get it, we're going to get it back to the person. We're going to open it up. They usually have pretty quick open access doors where you can just pop open. Everything's right there in front of you. We're going to turn it on. It's probably one of the number one things that's missed, right? We pull it out.
It has a switch or a button.
It has a little button. You got to make sure you turn it on. There are some that turn themselves on as soon as you open them up, but most of them still. And then once you turn it on, you just follow the prompts. It actually walks you through and tells you to do everything, right? It tells you to put the pads on the patient's bare chest. It tells you to continue chest compressions. It tells you when to stop, when to start, what to do, right? And once you put it on, it may tell you to clear the patient's chest, right? Because it's going to analyze that rhythm. It's going to try to figure out what cardiac rhythm is going on in the heart. And then it may tell you no shock advised, return to chest compressions, or it's going to tell you shock advised. And most of them will then charge up and there'll be an audible charge alarm. And then it'll tell you push the red button, right? It'll tell you to push the red blinking, clear the patient, push the red blinking button. You'll push that button and then it'll go back to compressions. And most products, the nice part is once you go back to compressions, it actually has a metronome timer on it. So it'll actually sit there and at 100 beats per minute, it'll just keep beeping away so that you know to keep on that pace.
Couple important things. It's an automatic external defibrillator. That doesn't mean it's just going to shock the patient and you,
right?
Because we don't want you getting shocked. You're going to have to take an action. It's going to tell you what action to do, and if you listen to that, it will tell you what to do. So there's some fear sometimes that people are like, if I put that on, I'm going to get shocked. The other thing I want to point out, and and James actually mentioned it, but I think it's worth mentioning again. When you start chest compressions, you need to continue those. So you may not be the one going to get the AED. The next person that shows up may be. Or if you're getting tired, because we do see that chest compressions get worse and worse and worse as people get physically tired, the next person that comes, have them do the chest compressions. You go get the AED. But what we don't want is pauses in chest compressions. We want those to be as much as possible. The only times we pause is when the AED tells us to stop so it can look at the heart rhythm, and then when it tells us to charge and then shock, and it will almost immediately tell you to start chest compressions again, because the key is to keep blood flow into the arteries that feed the heart, the coronary arteries, and to do that, we know we have to keep chest compressions going with as minimal pauses as possible.
Right. So we talked about this, apply AED to the victim's bare chest. And then one more thing, when EMS arrives, the fire department, first responders, law enforcement, paramedics, whoever it may be that first on scene, if there's a limited amount of responders, they may actually have you continue chest compressions, but they'll coach you through those things. So as soon as we show up, don't just stop, right? Keep going on those compressions. Like he talked, we want that good compression fraction. We want you to stay on the chest. So just when we show up, you're not quite out of the
picture. I mean, honestly, if you look at the data and the research, the things that save people's lives with cardiac arrests are good, high quality chest compressions and early defibrillation, which is AEDs or our monitors that we use. Those are the two things. All the other stuff that James and his colleagues do, all the things I do in the ER, none of them have been shown to be as beneficial as those two things. Good, consistent, high quality chest compressions and early defibrillation. And it's interesting, the AED world was created by a couple of studies that came out a long time ago and are still true. And they came out from casinos, and where casinos are monitored, the whole floor's monitored. They can tell exactly when somebody collapsed because they have it all on video. And they could tell by these times that they ran, that the earlier that somebody was defibrillated, the higher likelihood they had to be discharged to home from a cardiac arrest. So that's where the real push towards defibrillators started happening in the 90s and continues to today, and it still rings true. So all the fancy stuff we do with all of our medications and IVs and that really aren't the key. The key is those good chest compressions and early defibrillation.
Right. So now in any of these situations where you have someone that's been injured or has been in cardiac arrest, or it maybe is unresponsive even, we want to talk about one key thing that we think could really save a life, and that's the recovery position. So if you get onto somebody, their altered level of consciousness, they do have a pulse, but they're breathing more than 10 breaths per minute. We want you to place them on their side. You can see this is the recovery position, and call 911, okay? And then continue to check on people until help arrives. I think this is one of the most important things, right?
Yeah, I mean, vomiting if somebody who's passed out.
Mm-hmm.
You may come across somebody who's passed out because maybe they had too much of a wild night. You never know.
It teaches a lot to college kids.
You never know. And that keeping that airway open, keeping any vomiting that might occur from going into the lungs is crucial. And if you happen to be unfortunate enough to be dealing with a situation with a mass casualty situation, unfortunately, obviously we talk about stop the bleed because our country's had many occurrences where we needed to treat a large number of people. You may put a tourniquet on somebody, get the bleeding stopped, have to go treat somebody else because there's multiple victims. The recovery position is a great position to put them in because now you don't have to worry about them vomiting, their airway being compromised, and they're kind of in their own kickstand. They use their leg and their arm as a kickstand to keep them from rolling over.
Mm-hmm. Yep, and just continue to check on them. Make sure you call 911, and we have everybody coming. So I think that's kind of the basics of saving a life that we wanted to talk about today, and a lot of the things that we wanted to get out there to the community. But we're going to open it up to y'all now. And what questions or comments do we have out there that might be in our Q&A section?
Yes, thank you for that information. It's been very educational, very important stuff to learn. We had some questions about tourniquets. The first one was, are there risks to using a tourniquet?
So I will say there are risks. I can't lie and say there's not. They've been very much mitigated by the commercial tourniquets. The tourniquets this happens to be an area of my special interest. I've been doing law enforcement medic work for SWAT teams for years. And I've taught a lot of law enforcement officers, and there's a lot of information that comes from sort of the 80s, 90s around tourniquets, and they're dangerous and they cause injury to the vessels and people can lose their arms, etc. That's not entirely untrue. However, the risk is very low. What we teach is anything from 2 to 3 hours or less of a tourniquet time, the extremity should recover just fine. A lot of that depends on what caused the damage and how much damage was caused by the initial injury. So it may not be the tourniquet that causes the problems. It may be the fact that the arm was kind of blown up or the leg was blown up by a large injury, a motor vehicle accident, amputation from around here from farm equipment, gunshot wounds, knives, all those things can cause this. The tourniquets themselves are extremely safe, and that's why we recommend the commercial tourniquet, because it distributes the weight and the pressure more evenly and causes less vascular damage, and that the tourniquet can be on for hours. In the operating room, some of our vascular surgeons will put tourniquets on for several hours as they do a procedure on somebody as part of the procedure. So they're very safe, especially the commercial tourniquets. And in the reality, if somebody loses an extremity because of a significant injury, that's obviously not something we want to see, and it's unfortunate, but they're alive. And that's really the key at the end, is that we've saved their life.
Excellent. And just a reminder to the attendees, please type in your questions in the Q&A and we will answer them. Your answer, Dr. Larsen, goes into the next question. What are the characteristics of a high quality tourniquet and where do you purchase them?
I would recommend, if you're buying tourniquets, that you buy them from a reputable online source, and that being probably a medical supply source. The most common tourniquet was the one that we show, which is called a CAT-T tourniquet. That is by far the most common tourniquet out there. If you buy the actual CAT-T manufactured tourniquet, it's a great tourniquet. There are many knockoff versions that frankly you can get on places like eBay and even Amazon, where they're questionable in terms of their structural integrity. A really decent tourniquet, whether it be a CAT-T style, which has the what's called a windlass, the little rod that spins around and does the final tightening, or a ratcheting tourniquet, which is made by different manufacturers. RevMed's one of the most common for the ratcheting kind. They're not going to be super cheap. So you're not going to see tourniquets for $10 that are good, high quality tourniquets. They're going to be around $20 for a CAT-T that is a good quality tourniquet. Now, one thing about the CAT-Ts, those that have the windlass, the thing that turns, you don't want to train with those. You don't want to practice with those because you can actually wear that piece of fabric out. That needs to be the tourniquets you actually use. So be familiar with it, familiarize yourself with it, but don't use that to sort of, practice on, because it can wear that piece out, even in a high quality tourniquet. So if you're paying less than, probably less than $15, $20 for a tourniquet, you got to question sort of how good of a tourniquet is.
Thank you. The next question is about AEDs, and they asked, should I have an AED in my home?
I would think that if you were high risk for something, for some kind of cardiac event, that may be a possibility. In most urban settings in the state of Idaho for sure, you're going to have an AED there within 4 to 6 minutes, I would imagine. So in those situations, I would think, you know, it's kind of up to you what you decide. Dr. Larsen, I mean, I don't know.
Yeah, I think if you're as James said, if you're a high risk individual, so you probably are working with cardiology or at least your primary care doc, and you've had a history of arrhythmias before, you know, they're probably going to have a plan for you, or they should have a plan for you. There are vests that cardiologists will actually prescribe as a temporizing measure that basically sit on the person and until they can get an internal defibrillator placed. Those can be functional at home. Internal defibrillators for people who have known arrhythmia issues like VTAC. That would be specific. I would say that probably the problem with having an AED in every house is that they have a battery, they have a shelf life, they're not cheap, they're fairly expensive, so especially for a high quality one. And you're probably not going to use it in the time frame that it takes, you know, for it to expire, and you're going to be replacing it. As James said, law enforcement, first responders, QRU, obviously our paramedics have their more complex specialty monitors that function as a defibrillator, are within minutes from homes. So unless you have a special kind of need that you've talked through with your doctor, I would say it's probably not recommended that you have one. Now, if you're involved in QRUs or first responder in your community kind of work, you may benefit from having one for like a neighborhood watch. Maybe that's an option, that there's one in the neighborhood through a neighborhood watch group or something like that.
And that's what I was going to say. If you have gatherings of people, or you have people who are frequenting your community or your home or a school, church, business, community center, any of those things, we highly recommend that you try to find an AED to have in, you know, in those settings, in those areas. So yeah.
Thank you. I'm going to jump around a bit on the questions, but I'll get to them all.
Yep.
We have a question that says, any special considerations for gunshot wounds and bleeding in the field?
So I find penetrating trauma interesting. Like I say, that's kind of my specialty. So penetrating trauma is really penetrating trauma, whether it be rebar that goes through a window and penetrates somebody's chest during a car accident with a semi-truck, which frankly, I'm talking about things we've seen, versus a stabbing versus a gunshot wound. So they obviously have injury patterns that are different in the nuances that we deal with, but in all reality, they're a violation of the body that's now caused bleeding. So really the rules are the same. If I came upon somebody who had been in a accident out in the field harvesting with a conveyor belt, potato conveyor belt, and they had a partial amputation, I would treat that the same as I would a significant gunshot wound to that extremity.
Right.
Same thing with the chest, because the reality is it's the same physiology. They've violated their blood flow. It's no longer contained, and we want to stop the blood from exiting the body, because we need that to perfuse the brain and the heart. So in terms of special considerations, one of the things with gunshot wounds that we have to be leery of is our preoccupation with the one we know about. So if I get shot in the leg and it breaks my femur, that's the one I'm worried about, because it hurts really bad, and I can see it. What I need to make sure of is that there's not another gunshot wound, that I've been shot twice and once in the belly, and I'm not even noticing that because my leg hurts so bad that that's where all my focus is. So once you've got the bleeding under control on that extremity, you really need to do a bit of a survey and look for other gunshot wounds that we hadn't previously identified. That can be a real sticking point with us in the trauma bay. If you're unfortunate enough to be a victim of a trauma, it's an experience, because we strip you down. We cut all your clothes off and we look over every inch of your body. to make sure that there's not a new hole that you didn't wake up with that morning that we need to address. So you don't have to strip a person down. Actually, I wouldn't recommend you strip all their clothes off because we need them to stay warm, because hypothermia is an issue with bleeding. But you really need to do a survey and look to see, oh, there's another hole in their shirt with a little bit of blood on it. They have a gunshot wound in their stomach or their chest that we didn't know about. The key to that is for you to know and be able to tell the responders who are coming about that injury, so that they can address that with chest seals and other treatments that are above the scope of what we could talk about today. But the key is to make sure that you identify that bleeding as life-threatening bleeding, and we stop that as with the techniques we've talked about, compression and tourniquets.
Oh, very interesting. Thank you. One last question, at least so far in the chat, switches back to CPR. And it says, any key tips, things to know regarding CPR for infants and children?
Our favorite conversation.
Yeah,
Exactly. It's always rough to talk about kids.
Yeah, no, it is. There are some considerations. They have a lot of similar structures as adults, but they're smaller and they can be softer, right? They don't have as much muscle in the body, and the bones are still more pliable than an adult. When we're talking about child CPR, really most children we can do same as adult, or maybe just use one hand instead of using two hands. We're still trying to get that partial compression, trying to get that compression of the chest. We may not have to push as far down or as hard down, but we still want to allow for the recoil. When we're talking about infants and smaller, we talk about either using the 2-finger approach into the chest to be able to do that, or use the encircling with the thumbs, and we're going to push down with the thumbs. In late responder, we're going to talk about same stuff as adults, continue those chest compressions. In the infants, you may not have an AED with infant pads. With children, we can still use the adult pads. You may have to go front to back or kind of rearrange them with the heart in between the pads, because the pads are going to be too big for their torso. But in those situations with children, we still want to do the same type of compressions, same rates and things, but an application of AED is just important in children.
Yeah, and the key is to really keep that CPR going, and 100 per minute is a good rate for any of those to keep perfusion going. As James talked about, with the little guys, the really little guys, the infants, kind of reaching around them, grabbing them, and just doing that little squeeze like that is actually the easiest way I found to do that, because you're getting your thumbs really based in there, and you're still doing the 100 times per minute. You're compressing, an inch or an inch and a half versus the 2 to 3 inches in an adult. You won't feel bones break as often as the brittle older folks. So you may be saying to yourself, I'm not doing this well because they said there would be broken bones, but you can tell what that chest is doing as you see that chest kind of go down and back up. Same basic function though. You want to go in, out, and make sure you're going all the way out, letting that blood flow back in, and doing it at that 100 beats per minute. So continue to use the BGs, staying alive for that rate.
And one of the things too, differences between adults and children. Children more common go into rest due to respiratory issues, and adults go into rest due to due to heart issues, right? So when we have cardiac arrest in children, we want to be a little bit more proactive on some of the breathing, giving them breath every 15 or 30 compressions to kind of try to kickstart that system. So those are kind of the two things.
And the likelihood you're going to have a shockable rhythm, something that the AED says, let's shock this in a kid, is far less than in an adult. It's not zero, but it's less. The key is good, high quality CPR until you get the help there. If you can't get an AED on them because they're too small, don't stop doing CPR to try to get this AED on. Keep that chest compression going until help arrives if you can't get that on.
Yeah. Any more questions in the queue?
Yeah, sorry. One more. Do you have any classes that you offer for CPR and the use of AED?
Yes, the St. Luke's health system puts on AHA courses. They are available out there. There are a lot of community partners that also put on CPR and AED courses, lay responder courses, hands-only CPR courses. They're out there a lot in the community. In the Treasure Valley, there are multiple different training facilities. In the Magic Valley, there are a couple different training facilities, including St. Luke's Health System and St. Luke's Hospital. I don't have a good lead on where to access those and how to access those. Specifically, if you do go to heart.org, which was put in the chat earlier, you can find the training centers in your community that give those courses. So
yeah, the American Heart Association, Red Cross are places to look for. Local universities, colleges sometimes offer those to the community. So I would start with the American Heart Association and then kind of go from there and see if there's anything that you can find locally.
Excellent. I did put in the chat stlukesonline.org, and we do have an AED class in Haley. Those things change often, so you can look there. That is also where you find health talks if you're interested in more of these virtual opportunities. Another question was a little different. It said, do you recommend the anti-choking plunger-like device?
I'm guessing that they're talking about the little syringe thing.
Yeah.
And I've seen those, and I haven't read enough articles on them to pass an opinion or a recommendation on those.
I can't say for sure. I mean, when you have a choking, say, infant, there's the techniques that are taught through CPR and CPR certification about back blows, holding the infant upside down, sweeping the mouth. I don't know enough about those to say how effective they are. They're not something that we utilize, frankly, in our world. When we have tools, forceps and stuff, we go after stuff with. I think a key to this conversation about choking is once somebody is choked to the point where the child or adult, to the point where they're unresponsive and don't have a pulse, CPR is the recommended key. That's the recommended how to address it. Starting CPR. Is what they need. So if they're in the middle of choking, there's Heimlich maneuvers, there's these, like say, these back blow maneuvers that are taught during CPR courses, which is a little beyond the scope of what we can do today. But the key, I think, to take on from today is if somebody is choked to the point to where they're unresponsive and don't have a pulse, start CPR and get their blood perfusing to their heart and their head.
All right, we have one more kind of comment. Thank you in the chat. It says, thank you to fire, police, EMTs, as my friend had a sudden a sudden cardiac arrest at my house in March of 2020, out of the blue. And fortunately, the fire station is down the road, arrived within 4 minutes. After CPR and AED and amazing care, she now has a defibrillator and is doing well. Thank you for the excellent presentation, is what they said. And I definitely echo that. Do you have any closing thoughts?
No, I thank you for the call out. I think it illustrates the importance of early addressing these things early, whether it's bleeding and getting the bleeding stopped with compression or tourniquets, or starting CPR early. It can be scary. James and I have been doing this for a long time. So for us, it's kind of normal, and we talk about it as if it's normal, but I go back to the first time I had to resuscitate somebody. It can be scary, but sometimes, for the average person is the best hope for those individuals. So acting early, again, we talk about don't panic. That's the key to disaster is to panic. So don't panic. And, police, fire, EMS can't be everywhere at once. So we got to take care of each other.
Yeah, no, I'm with Dr. Larsen. And if you have more questions about this, reach out to your local EMS provider, paramedic providers, ambulance companies, fire departments, health systems, clinics, and to try to get connected into any of these resources, any of this education, and just being more aware of kind of what's out there. So.
Awesome. Thank you very much. And we appreciate your time and expertise and all of the tips we learned about saving life. And those are things you do every day. Thank you.
Thank you.
Thank
Thanks,
you.
everyone.